Welcome to this session on plan and challenge for using a digital tool. We have three persons who will be presenting on three different topics. Perhaps you can activate the camera. So we have Dr. Marie-Ève Raguenaud, who is a consultant at the WHO TDR department, who will be presenting on the result of the survey assessment on the use and evaluation of digital health technology for malaria. Then Ryan O'Neill from the Global Malaria Program of the World Health Organization will be presenting on data sources and linkage of malaria data for a more comprehensive surveillance system. And finally, we will have colleagues from Senegal, Dr. Ibrahima Kaliloula Dia, who is the Director of Digital Health Department of the Ministry of Health in Senegal. And he will be presenting the National Strategic Plan for Digital Technology, giving the example of Senegal and sharing this with you. The way we will be proceeding is every presenter should do their presentation in 10-12 minutes. And then we will leave a couple of minutes to take burning questions. And at the end of the three presentations, we will have around 15 minutes to discuss further. But please, if you have comments, questions, use the Q&A section that you have on the Zoom to post your question, and we will try to answer during the session. And if there are also burning questions that you have, then please raise your hand and we will try to give you the floor for asking your question, or we will take some questions from the Q&A to launch the discussion. We would like this session to be informative, but also try to have it interactive. So it's not always easy when it's virtual, but let's try to do it this way. So let's start. I give the floor to Marie-Ève Raguenaud with our presentation. Thank you.
Okay, thanks, Corinne. Good. So, like Corinne said, I will be presenting the results of a pre-conference situation analysis that we conducted in the past few weeks. So these should be considered preliminary results to give us some insights on the topic. So there's a clear need for all countries to be able to implement digital technologies and be part of this global digital health transformation. So we wanted to have a quick overview of where we were at in Africa, looking at various aspects of digital technology, specifically for malaria. So first, the type of digital tools that are already introduced by national malaria programs. Second, the challenges that are faced by national malaria programs that could be improved by a digital solution. Third, the barriers to the introduction of digital tools as perceived by the national malaria programs. And fourth, the types of evaluations done by malaria programs on these tools. So we developed an online questionnaire with input from CRS and from the Global Malaria Program of WHO. And we send it first to the 13 countries that are part of the TDR Optus MC project. And some participants at the conference also received the link to answer the questionnaire. And by the way, we were only targeting the national malaria programs. So 13 countries responded so far, all from West and Central Africa. 9 out of the 13 responders were the national malaria program coordinators, and the others were members of the staff members of national malaria programs. So for the first section on tools, digital tools used, we in the questionnaire, we grouped together the digital tools according to their main functionalities. So we used 5 functionalities: patient care, program management, surveillance and monitoring, e-learning, health worker decision support, and prevention. So in the category of patient care, we see that actually few countries have introduced digital tools. 5 of them, for example, use telemedicine or virtual consultations. The yes answer was split actually in 2 categories. The yes, the tool was introduced only in a pilot phase, and yes, fully introduced over the whole territory. Now, if we look at the tools for prevention, here we see that more countries use digital tools, with 11 that are using a tool for SMC. Of course, we have to keep in mind that most respondents were part of the OptSMC project. But nearly half of countries use some digital technology for vector control, in particular for bednet distributions. We see that a few countries are trying out tools for other prevention activities, such as chemoprevention for pregnant women and even for infants. If we look at the category for program management, 2/3 of countries use tools for procurement and also for a malaria data repository. 2 countries reported using a tool for actually, this is for the surveillance. If I go to the surveillance and monitoring, most countries use a tool for case notification, such as the DHIS2, which was given as an example. We see that some countries use tools for drug efficacy surveillance, entomological surveillance, even genomic surveillance. Some countries use, few countries use a tool for adverse drug reaction reporting, which is not specific for malaria. And we included also in the lists the civil registration and vital statistics system, which is for death notification with the cause of death, which is a tool that's not specific for malaria, of course. For the e-learning and health worker decision support, here we see that there's actually a lot less countries that reported using some tool, with actually 4 of them using the WHO malaria toolkit application. And then we made a summary of the top 4 tools used. So the 4 tools used by the highest number of surveyed countries. So we have the electronic system for case notification, the tools for SMC, the data repository that's specific for malaria data, and tools for procurement and stock management. Then we had a series of questions on the different types of challenges faced by national malaria programs that could be addressed by digital solutions. So here I'm just showing a summary of the most frequently cited challenges that programs mentioned could be improved by digital solutions. So we see that they cover a large spectrum of program components. So countries agreed that, for example, that malaria data quality and data reliability and recording could be improved by a digital tool. Also, the availability of supplies, whether it's human resources or equipment, could be improved by digital tools. Quality of care, specifically adherence to guideline and staff supervisions, could be facilitated with digital tools. And tools were also thought to be able to provide improve program accountability, for example, by providing feedback to the community. So then countries were asked to select barriers for the introduction of digital technologies. So it was a yes, no, uncertain answer that was required for each of the potential barriers that you see listed here. So first you see that that actually many barriers were selected, all of them. And the top 4 barriers that were selected by the highest number of countries relate to the cost of tools, the cost of rollout activities and the cost of tools, which comes in fourth place. The lack of internet connectivity or mobile network, and also the lack of involvement of end users when introducing a tool. Then the last section was on evaluations of digital tools. So this was filled by only 9 countries. So the different types of evaluations were listed, and again, countries had to answer yes, no, and certain. So we see that half of the countries reported having conducted some needs assessment, which is not a research per se, and it's done generally before introducing a tool. Half of countries have done a usability study. There were some efficacy, effectiveness studies that were done, a few economic evaluations, and very few countries mentioned having done some other type of implementation research. And the gray color corresponds to the answer uncertain, and interestingly, many countries were uncertain about whether they had conducted the different types of evaluations. So it could be that the coordinators of the national malaria programs who responded to the questionnaire and had to do so in a very short period of time were unsure about the different types of research, or maybe they just didn't have that specific technical information. And there was a last question to which 10 out of 13 countries answered yes, and which was a question on whether they were interested in being trained on implementation research. The first section actually of the questionnaire was on transversal issues, which I show here last. So we had half of the participating countries that reported having a national digital health strategy, half reported having a digital health platform, less than half had e-health standards, and actually no country reported having a unique patient identifier. And all of these were defined in the questionnaire. So as a summary, of course, these are results from a quick situation analysis. And what we can say from this first wave of respondents is that most countries have already introduced tools, actually a great variety of digital tools. Many national malaria programs are convinced that digital technologies can help them address specific challenges they face, and this for various components of the program. Yet they're facing many barriers, such as the high cost, not just for the tool, but for the rollout of the related activities, and also some structural ones like the connectivity issues. There's a need for more research related to the introduction of these tools, in particular implementation research, and there is willingness to do so. And last, we can say that efforts to conduct needs assessment and to develop national digital health strategy and e-health standards will definitely contribute to the sustainability of the global digital transformation, including for malaria control. So I'll stop there and be ready to answer any burning question.
Thank you very much, Marie-Ève. It was clear, and I see that there is no burning question, but there is a question in the chat box that perhaps you can answer live, Marie-Ève, from Anna Franco, who was asking if it was possible to get information about what exactly were the different tools being used, and whether they were openly available or were they specific to particular settings?
Yes, so actually in the questionnaire, we didn't name any tools, and the respondents didn't, whenever they answered that they were using a certain type of tool, they weren't asked to name it. So actually we don't have the information about the exact tools that were used, only the types of tools. We would need to go back to the countries actually to figure out what tools exactly they were using.
Okay, thank you. I see that there are other questions posted in the chat. Perhaps you can have a look. And we should now move to the second presentation of Ryan on the data sources and linkage of malaria data for a more comprehensive surveillance system. Please, Ryan.
Yes, hello everyone. So I will be speaking to you about the National Malaria Repository and data use, Malaria Repository, the Malaria modules, dashboard, and tools. The modules, Malaria modules is a foundation of the work that we do with countries to help strengthen their health information system and standardize and harmonize their data set. The metadata that we provide includes data elements, indicators, forms, dashboards. Dashboards are charts, tables, and maps, all based on our guidance and documents in consultation with our partners. The modules are a big component of the tools developed to disseminate WHO recommendation and guidance to countries, especially those using DHIS2. Those using DHIS2 can readily download these modules and make use of them. These modules are accompanied with guidance documents and tutorials. They are currently, base modules are installed in over 40 countries, malaria endemic countries. The standard malaria module aggregate is a set of, again, data elements, indicators, dashboards geared towards data that's routinely collected at health facility level. Generally, this is monthly data. It contains data in the areas of cases and deaths, laboratory results, case investigation, foci, population at risk, routine interventions, and some stock elements. On the case-based side, we also have a patient-based module, also known as Tracker in DHIS2, which contains a standardized patient profile, unique identifier, and elements similar to those that are in the aggregate module. The data collection is set up in stages, from diagnosis to treatment, to case investigation and classification, and foci investigation and response. These tools are integrated in a broad set of tools being offered by WHO in a WHO app, which contains different modules from different programs. And we have done a lot of work to standardize and harmonize overlapping elements such as the denominators, total all-cause outpatient, deaths, inpatient, other denominators such as population, and as well as the patient profile and naming conventions have been standardized across these different modules available from the different WHO programs. Based on these modules, we've built upon the standard modules for the repository. Now, the repository is seen to be a one-stop shop for all malaria-related data, information used to guide the National Malaria Control Program and to provide information for decision-making, planning, and action. What questions are we asking or should respond? What are the questions that the repository should answer? So we're asking whether the program is achieving their goals. We're tracking the trends in cases and deaths, testing and treatment, intervention coverage, general surveillance and monitoring, human resources and training. And this is being used or should be used for strategic area modification and to address any funding gaps and planification of any interventions to be distributed. We present epidemiological data from burden reduction setting to elimination setting, whether it be aggregated module or the case-based patient level data module. We have specific dashboards pertaining to intervention assessment. We're trying to assess the proper distribution of the interventions, the coverage, and whether there is impact. We're also tracking the commodities. There's a module on supply chain, which monitors the delivery of the different commodities, LLIN, RDTs, ACTs, and monitoring stockouts of these key commodities. Quality assurance with regards to the elimination setting, the percentage of microscopy results cross-checked, and percentage of testing laboratories participating in the microscopy quality assurance assessments. We also use, there is a survey module that is being designed to bring in all the surveys, the latest surveys that are available at country level. And we are using that to correlate data coming from routine as well as those that are available in the surveys. Entomological modules and dashboards are also available where information is provided on vector species, insecticide resistance monitoring, and also maps are generated in function of the vectors and IR, insecticide resistance susceptibility. There are data quality dashboards specific to the data being captured, which we use to highlight any discrepancies within the data. So we have things, charts, monitoring the coherence between variables and monitoring the coherence of variables over time. There's also the completeness of reports and completeness within the reports, whether reports are complete with regards to specific malaria-related variables, not just the entire report, and also the timeliness of these reports once submitted. Now to this slide represents the diagram of the malaria module. We can see that the routine system in DHIS2, which normally collects health facility-based data, is represented by this module icon here, which has either the aggregate or case-based module installed. These modules can be assigned to specific areas. So within the country, you can have districts reporting using the aggregate version, and other districts that are with lower burden can also use the case-based, and together they are seamlessly combined at the higher levels, and the information is presenting the dashboards. As I mentioned, there are also different modules that we're building on top of the routine modules, which are the interventions, the ento vector control modules, funding, stock management, climate, human resources, and we're also looking into the document library where we have documentation also available. The ento and vector control modules, we have 7 modules that are currently being published. This is also based on the guidance being generated by the vector control department. And there are a series of modules and dashboards, as well as guidance related to these. Standard reports that we use to present data at the district level or the provincial level, even at the health facility level, compares data over time, monitors trends, decline or increase in certain areas, depending on the indicator that you're looking at, and present information on funding and some other operational elements such as LLIN distribution and wherever possible, IRS spraying. We're developing additional modules to add it to the core, which are the stock management modules, the district management dashboards. We're currently working on the SMC module. We will implement shortly the rapid impact assessment results, as well as the surveillance assessment results, human resource and operation planning modules. These are packages that can be installed individually, or they can be installed altogether. Now, currently, we have installations in different phases in different countries. In Guinea, Nigeria, and Uganda, they are at the phase 2 level of the implementation, meaning that they have linked their routine health system to the national repository, and they have various additional modules installed, and currently working on training subnational users on how to use and possibly also partners on how to use and contribute to the system. Burkina Faso and Cameroon have also started. They're in phase 1. Mozambique, Tanzania, and Cameroon are implementing the methodology, but not necessarily the DHIS2 functionality. They might be using other digital tools to achieve the same results. We have planned installations that will occur shortly in Sudan, Ghana, and the Democratic Republic of Congo, as well as Kenya and Guinea. We plan to use the installation to support the following: stratification exercises, rapid impact assessment, surveillance assessment, and EPI reviews. We'll be doing this shortly in Sudan, piloting these different modules that are currently under development. And once this exercise is finished, then these modules will then be published. This is something that we're looking towards the end of the year. The main tool that's being used to support the dissemination of the modules, whether it be the base module or developing the malaria repository, is an application developed at WHO called MD-Sync, which allows for metadata as well as data to be transferred between different instances of DHIS2. So different installations of DHIS2. It allows us to execute updates, to provide support remotely, and also it allows for countries to submit data to the various levels of reporting when they decide that they want to share this data. It makes it very easy to transmit data between different instances of DHIS2, and at the global level, as well as the regional level, there are installations of DHIS2 being used either for surveillance workshops or for the global malaria reporting. Another set of tools that are being developed, one is the bulk load. It's being used to allow for generation automatic of Excel templates based on the data set within DHIS2. So if you're looking to collect data from external systems that are not using DHIS2 or other platforms, this is a simplified way of generating an Excel template, which is generated directly from within DHIS2. And it will populate where data is found. It could be used for many reasons: for sharing of data, for correction of data, and also populating the database when you want to upload that same Excel sheet into DHIS2. This is accompanied with data checks for duplication, and the validation within the Excel template is built in.
Thank you very much, Ryan. It was very clear. I see that in the chat box you have a couple of questions, but we can take one rapidly. There is a question on the where all the modules that you're presenting, where they can be found, and if they are available to country or organization online. If you can.
So at present, we have the base modules, which are currently available. They're available on either from the WHO website or from University of Oslo, DHIS2 website. They're promoting the WHO apps. So within the WHO website and from the University of Oslo DHIS2 website, the base modules can be found. These are the malaria modules, other modules for other diseases. And we've also published there the stock management modules. The data quality module is there, and we are slowly developing the other modules. The district level and provincial reporting will be available shortly, and the other modules you mentioned, as they have been tested, piloted, we will then release them. Within the, I didn't speak too much about this, but within the MD-Sync, there is a small widget that appears on the dashboard that can be used to manage these modules. Now, it's sort of like an application store, if you're familiar with the iPhone or Google Play Store, where whenever there are updates, if you have one of these modules installed, you will see it on your dashboard, and you can use the MD-Sync tool to update that module. You can also use it to look and see what is available in the store, the place where we will publish these applications, and then install it from there. You will get a guided tour on how to install and customize the tool using that.
Very clear. Thank you. Thank you very much, Ryan. Perhaps you can look at the question in the chat box. So now I give the floor to Dr. Ibrahima.
Well, good afternoon. Many thanks, everybody. So I would like to thank you, first of all, for this invitation. Being able to share with you what we are doing. I am the coordinator for the Digital Health Department for the Ministry of Health and Social Action in Senegal. It is a real honor and a pleasure to share with you what we are doing in terms of numerization and digitalization. So the service that I had is created and was created in 2016. This is a service that deals with the digital map, which is the organization of the healthcare for the digital health and also the health observatory. So we have three main missions. Can you see that now? Yes, yes, it's perfect now. Okay, so what we have done is that in 2019 we have drafted the vision, which is the strategic plan for the digital health for Senegal. This was drafted in 2019 and it was launched in the presence of two ministers, the health minister as well as the telecommunications minister. During this launch, the two ministers launched a partnership agreement, partnership convention, because we had the health minister and the telecommunications minister, and they both stated that they needed to be in concert in order to make the health system a digital system. So in 2020 and 2021, we had to reflect and think about the project because we accept the vision, but this is just at the vision stage. Is at the orientation stage. This is not at the stage of project and activities. So in 2020, we gathered all the stakeholders and actors in the health sector in order to see what are our projects, what do we want to do, and what are the digital platforms that we have at our disposal and what is lacking. So we had a lot of projects put forward, proposed at the beginning of the discussion, and we started with 30 projects, and by the end of the year we had reduced this to 10 projects, and then by the end of the year the ministry had its own document which has a digital program for the health ministry, which is different from the strategic plan. So we did this program in 2020, but yet we understood that we needed to go for further. Why? Because this program had been estimated at about 27 billion CFA francs. 27 billion CFA francs. This is about $50 million. So in 2021, therefore, last year, we had the support from the planification department that told us that now we need to go for the money. And that's how we got in touch with the Ministry for Planning, Economic and Planification, which deals with the big state projects. So in 2021, we had several meetings. They recruited a consultant who took a document that we drafted in 2020, improved it, and this enabled us these days to say that this particular program has now become a state program simply because the consultant did some good work and we really value what he did. We validated it and then we decided and we said that this program has managed to go through the maturation filters, as we say in the country. So in Senegal and maybe in lots of countries in the world, when the ministry has an important project, the project has to be assessed by the planning minister to see whether that project can be feasible and have a strong impact. So we succeeded in going through this particular filter and selection criteria. So in 2022, we are in an implementation and technical and technological phase. So now we are starting talking about some digital solutions. We are starting to talk about architecture and urbanization of the service. That's where we are right now. So As part of this program, we have the following projects, 6 major digital projects, which are quite well known, as you find them in a lot of programs, which is how can we make sure that each Senegalese person can have his or her own shared patient file that can be shared on a national and international level. That's the first project. The second project rather, is a telemedicine project. We want for our health services to have some telemedicine rooms in order for them to be able to be connected to some specialists as and when needed with some specialists who might be in the regions. Because we have a private side that is left to the private sector in order to connect people with different platforms, but we have that telemedicine project. Now we also have a third project, which is a hospital information system, which is how to make this activity digital. We have a fourth project now, which is about a geographic health information system, and this is everything to do with the health mapping. We have project number 5 regarding the medicines. How can we ensure that medicines are secure and are dispatched accordingly. And project number 6 is digitalization of community health processes project. So these are the 6 projects that we have and on which we are working at the moment. So the program is made up of 3 main components. Well, component number 1, which has to do with anything to do with the framework, anything that has to be studied preliminary. You have component number 2, which has to do with conception, development of software and deployment of such software. And we have component number 3, which regards anything to do with equipment, with capacity building and training. So these are our 3 main components, which are part of the GG Health program. Technically, what we want to do is to place the patient at the heart of what we do, the patient at the center of our health system. So we work for the patient to have a unique identification in terms of health. We work so that everything that has to be coded in order to facilitate interoperability. I can tell you that we are coding the medicine, the places where this can be dispensed, as well as all the connected work, which is quite complicated and difficult, but yet these are the preliminary elements for a successful system. And once this will be in place, we'll then be able to develop a number of applications around this that will work well with some gateway platforms. So this is what we have called the integrated system for health management, which is the technical and technological side, which is different from the programmation plan and strategy area. So now I'll go quite fast on the point concerning Sante.sn. So I will go fast around this, and let me tell you the constraints that we have noticed. These constraints do not prevent the country to start working. Does not prevent the country from having some projects. So we have noticed that there was a recurrent unavailability of power in some of our health centers and positions. We have noticed that there was an unavailability of the internet also, which is quite strange because we have some very big telecommunications companies and the internet is available in Senegal, but yet there is a cost associated with it, which represents a problem, which means that now we have some health centers and some hospitals which have some problems in order to have some reliable fast internet. This is what we noticed, and we have also noticed that in terms of cabling in our health structures, there is a lot to do. Everything must be done because cabling and cables is not something that can enable us to have a real digital system. As for the other constraints, as you know, in that system, this is the multiplicity of initiatives as for COVID, which has helped us in one way or another, fortunately or unfortunately, but it has helped us to improve the digitalization of the health sector. And what we note is that now there are many stakeholders, many services, many bodies that want to become digital. And as you know, this is a good thing because now we have finally understood, and many people have understood that this is essential, but yet that needs to be organized now. And that's not easy. And that's why I will finish with the lessons learned. And what we have learned is that in the health ministries in African countries, we often have some management teams which are already dealing with some digital health in a piecemeal manner. For example, we might have a different department. We can have the health management team. We have maybe a digital health team. So therefore, we have different organizations, different bodies governing digital health in our countries, but yet it's absolutely essential for people to be trained. Because if they are not trained to the digital health and to the digital elements concerned in that area, they will not be able to go in the right way, because in order to do so, you need to have the proper training. But because digital health, it represents something that has to be done as a matter of proper occupation. No, this is quite complex because we need many organizations, a lot of negotiations, a lot of regulations around it, as well as a lot of consensus before we can start in that area. So these people must be trained correctly in order to understand that. The second lesson learned is that when you say that you are dealing with digital health or with digital IT systems and so forth, but that you mention digital health, you need to know how to access funding and how to access money. This is very important because this needs some resources, and our health structures are not equipped in terms of computers, in terms of tablets, and not even in terms of internet. So therefore, we need to mobilize some relevant budgets for this. And if you do not know how your country works in terms of budget, in terms of planning, and if you are the only leads going towards this in your country, you will encounter some problems because you need to know which way to follow, which path to follow. Normally, you have to work alongside the ministry, whether you're talking about the finance ministry or the budget ministry or the economics ministry. You need to do so in order for projects to be accepted. The third lesson is that we need more than goodwill from the states. We need proper commitment from the states. So willingness is one thing, but yet commitment is something stronger. We need some commitment, otherwise we will not be able to go forward, because health is a complex area where people know the medicines, no problem, they know the vaccinations, no problem there, but they do not know what digital health is about. And when you ask for a lot of money, they don't understand. They're just saying, well, what will that money be used for? And therefore, the state must be able to push forward to say, we are the state, we want this to take place, such as what our president stated. He said that you want 600 billion CFA francs. Okay, I agree. But first of all, we need to digitalize the system. And then afterwards, I will give you that 600 billion. So this is what we need in terms of commitment. And the third lesson learned, which is very difficult, but yet it is at the something essential for digital health in a country, which is that we need to have two golden rules as managers. We need patience. We need patience for digital health because we will not be able to do everything. You could start things and other people might complete this because it takes a long time. It's very slow. So therefore, you need to be patient, and you also need to ensure that you have involved the most important stakeholders. This is a very important point because if you do not involve them, because you're dealing with digital health, you're not dealing with vaccination, you're not dealing with hospitals, you're not dealing with health positions or medical equipment, you are dealing with digitalization. So therefore, you need to go towards other stakeholders, or they have to come towards you, and in any way, shape, or form, they need to be involved because in the end, you end up helping them to work better. So these two golden rules are very important. And the last lesson, and I will conclude by stating this, and that's something that I've noticed as a digital health manager. I see that we need really a lot of human qualities if you want to succeed with digital health in many countries, and that's why many countries have failed, because they're stating the term digital health without necessarily listening, and they're very detached from what they do, because otherwise there will be a lot of frictions between digital health and the different management and services teams and departments that have been in place for a long time, but that yet need to be improved. So this is some of the lessons learned, and this is what I wanted to share with you. And I hope that I did not go too fast, and I hope that this will help the members of the panel as well as those who attend this session. Many thanks. Many thanks, Dr. Ibrahima. It was very interesting, and it's important also for us to have the opportunity to understand on the ground how this can be implemented at the national level. And I think that we have properly felt how much we need to be brave, patient, and how we need to involve all the stakeholders. And I now see that we have some questions. And maybe we can now give the floor to Mr. Mohamed Avjirogva. Sonia, can we give him the floor for him to ask his question? We have about 10 minutes available in order to talk around these three presentations, which, as you have seen, have shown different panels. The first one has shown that the digital tools are used in the malaria sector and used for various functions, not just for monitoring, but also for some other function in terms of help for patients and procurement and so forth. And you have also seen, we have also seen that we have this depository that in a comprehensible manner is trying to link the different data linked to malaria in order to optimize this as much as possible. And then we have seen on the ground how we can also set up a national strategic implementation plan on the digital strategy and tools. So therefore, we accept all the questions that could come our way. Just
I see that there was a comment from Meredith, who was agreeing on the equipment digitization teams with an understanding of project development, budget request, and she was agreeing on this point. I see that Mr. Ibrahim Mbaye is asking a question about the barriers for interoperability between the different platforms. I don't know, Ryan, you might have an answer to this question.
Yes, hi. What we're experiencing, especially with dealing with the repository and also the data collection subnational level for the World Malaria Report, is that, and we're trying to address that with the systems in using DHIS2, is the different formats, the different disaggregation of data, different technologies being used, and the barriers are normally closed systems do not allow for programmatically for one to design a program to fetch the data out of the system in a sort of automated fashion. More and more programs are designed with this application interface part, which DHIS2 has, and a number of other tools have, which allow us to build the different, to link these different systems together using some small code, just to pull data from one, put it in the format necessary, because you have to deal with the disaggregations, which might have been different, or you might have to combine data elements, data points in order to get the result you're looking for in the other system. So this can be done programmatically. This can be done with different tools that have been designed to work with databases. What we're looking to do is to make it as simple as possible. And with the tool I mentioned at the end of the presentation, MD Sync, it allows for this. Even when you're looking at two same systems like the DHIS2, you need to actually worry about the disaggregation, the different age groups that are the data is being collected, the different levels that are being used, to make sure that they're aligned when you're pulling from one system and putting it into another. We're looking to develop, at least it would be good to know the top tools that are being used when we're looking to get data into the repository, and then we will be developing interfaces that will make it readily usable for many countries. So there are tools that are being used for SMC, for mass distribution campaigns, for IRS spraying, that we would like to link up and make it easy for the countries to get that information to a portal, a repository, or a depot.
Thank you, Ryan. Perhaps Dr. Ibrahima.
Do you have maybe an answer on that? Did you have any issues when it comes to interoperability? You mentioned in your presentation that there was a lot of enthusiasm for digitalization, but I guess that this translates into having some tools that do not comply or were not really compatible with the interoperability aspects. So do you have any kind of processes or specifications which are defined in order of which digital tools you can use in Senegal when it comes to the interoperability aspect? Yes, thank you very much. We have created a committee, a technical committee, which has been created through regulatory pathway, which is made up of a working group and different working groups. And one of them is dedicated to the interoperability aspect and is headed by the director of the IT system. And as this hasn't been standardized or decided what we're gonna do, so the person who is involved in doing that, we haven't quite managed to have a meeting yet with all the partners to actually discuss that point and initiate and start something. So the interoperability for the systems dedicated to the patients, this is something that we will address. So if we are able to qualify properly, so by developing APIs. An API is like a software that you can use to develop your software. It means you don't have to replicate the software. So like, let's say a healthcare worker, a name, the identification number, and so on. We can use an application that you can use to develop your own application. So you don't have to do that again with all the personnel or health personnel, and anybody can use it and communicate. So this, but we haven't quite decided how we're gonna go around that, and this is something we've been considering, but hasn't been finalized yet. Okay, thank you. I can't see any other questions in the chat box or in the Q&A section, so I guess that we are coming to the end of the day, and it could be that maybe we have run out of energy. So this was the last section of the day, which brings our first day to an end. I hope that you were able to attend some interesting sessions, and I do hope this was an interesting one for you too. We are back tomorrow, 12:30 GMT time, with a first session which will be about regional and networking aspects. So that's 12:30 GMT time. And by the end of the day, we are fortunate to have our colleague Dr. Arnaud from the WHO for Global Malaria Department, who will deliver a keynote speech on the malaria. And I'd like to invite you to join us for that at the end of the day. So I believe we can now bring this session to an end. I will give the floor quickly to Hélène, Marie-Ève, or Ryan, if you have, or Dr. Ibrahima, if you have any last message that you would like to share with us before we bring that to an end. Thank you very much to the three of you. It was very clear and very interesting. Do you have any concluding remarks? Marie-Ève, Ibrahima, Ryan?
If you don't have any remark, I think we need to close here. And I thank you again, all of you, for your presentation, and I thank all the participants as well to have taken time to listen to this presentation and this session. Thank you very much.